Good morning, everyone, and welcome to the Project Echo. This series is about intellectual disability information and education and is brought to you by the Vic PHN and the Spider Project, supporting people with intellectual disability to access health. This is the third session in Series 3 of this Echo network, and it's Tuesday, the 22nd of November, and this session is titled Positive Behaviour Supports for People with an Intellectual Disability. So I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're all zooming in from today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination of First Nations peoples and organisations, and we will work closely together on closing the gap. So my name's Robert Ward, and I'm a full-time GP in Geelong, and my role is as the GP facilitator of this Echo series. And I'm also the father of a 25-year-old young man with intellectual disability. So hopefully throughout this Echo series, we're beginning to gain a better understanding of how people with an intellectual disability interact with the primary healthcare system. We've been introduced to the concept of reasonable adjustments and the changing needs of people as they transition through life stages. We've also learned that people with an intellectual disability often have difficulties with communication, and sometimes that communication is through behaviours, and these behaviours can be difficult for us to understand. Often, in general practice, a patient can present with a parent or a carer and the story of a behaviour of concern. And this may be a significant behaviour that threatens the patient's well-being, the staff's health, family stability, accommodation or workplace viability, and a behaviour that can limit a person's opportunity to participate in their community. So in the fast pace of general practice, we're often asked for a quick fix or a solution, which can often be a near impossible task. Throughout this series, we've also learned that good care of people with intellectual disability requires a team and a collaborative approach. So it's really great today that we'll be joining by a collection of behavioural support practitioners. So for those of us who thought the PBS was the pharmaceutical benefit scheme and reached for our script pads, we should probably be thinking PBS as positive behavioural support. So today we'll hear from positive behavioural support practitioners, who they are and what they do, and how they'll be interacting with our patients and the carers and the parents and others supporting people with intellectual disability in our community. So I'd like just to go through the etiquette slide to start with. Actually, we might just introduce ourselves to start with. We've got Whitney and Gemma from the Echo project. Do you want to give us a wave, guys? And they're behind the scenes and they'll be running the chat. So if you've got any questions, please feel free to put them in the chat. We've got Adam Lyons, who's going to be our guest speaker today. And Adam's a behavioural support specialist from Lancaster Consulting. Jane Tracy joins us. We've known Jane. Hi, Jane. Jane's a GP and a former director of the Centre for Developmental Disability at Monash Health. Zach also joins us. Hi, Zach. Zach was our presented a case last week or last fortnight, and he's a behavioural support specialist with GenU. So our other person on the panel today is Nikki. Hi, Nikki. Are you able to introduce yourself?
Hi, I'm Nikki. I'm a behaviour support practitioner with Clear Thinking Mental Health Group. Welcome.
And Nikki's going to do our case study today. I see Kerry's there and Nicole, both from the Spider Project. So we might just go through the others. Good morning, Alison. Do you want to just introduce yourself, Alison? You're on mute.
Yeah, I was trying to find the unmute button. Hi, I'm Alison. I'm a behaviour support practitioner. I work with Zach.
Well, welcome. There's 4 of you today. I think I was trying to work out with Adam what's the collective noun for behaviour support therapists. John, how are you, John?
Yeah, good, Rob. Thank you. I'm John Newman. I'm a GP in Geelong West.
Welcome again. And Angela joins us. You're free to come off mute, Angela.
Hi, everyone. I'm Angela Bromer. I'm actually joining in. I work in a regional education role, and someone had suggested I join in these Echo sessions to see how they run when I met with someone from the Vic PHN last week.
Great. Well, welcome.
Thanks for having me join in.
Welcome. So we'll just put up the just reminders of the etiquette slide. So it's all about sort of interacting today. So if we can keep our videos on and keep your mute button clicked when we're not talking, if you can make sure you're named properly. Please feel free to use the chat tool. The Echo team will be monitoring the chat, and particularly with any questions you might have. We'll have lots of opportunity for questions as we go through the session. As always, we'll be recording the didactic talk for people to look up later on the West Vic PHN website. Won't be recording the case study. And also please be respectful of confidentiality and of other participants during the chat. And we might just keep going. So the agenda today. So we're going to have a didactic presentation, and that's going to be with Adam Lyons, who's the Managing Director and Behavioural Support Therapist at Lancaster Consulting. And we've got Jane and Zach as our panel members today. And so we've already introduced Nikki down there, who is going to present as a case to help us discuss positive behavioural support. So if we look at, just to remind ourselves that these Echo sessions are about case studies. So if anyone has a case study they would like to present in any future Echo sessions, if you've got any questions or difficult cases, please feel free to click on there or go on the link in the chat and give the Echo team your case study for them to help put on. Also, just a reminder about professional development. It's getting to the end of the triennium, so there might be a few extra little points in there if anyone needs those. There is a survey, so if people can please do that, I think it helps the Echo team prepare for future Echo and future events, and it's really helpful for everyone. So I'd just like to remind us of the learning outcomes for the season, or for this series, is to recall the terminology when describing intellectual disability, identify solutions to support people with intellectual disability, access primary health care, to assess and acknowledge the disparities and health inequities in accessing primary health care for people with an intellectual disability, to understand the United Nations Convention of the Rights of a Person with Intellectual Disability, and to summarise how to implement reasonable adjustments for people with an intellectual disability in the primary healthcare setting. So we're going to make a really good time today. So I'd like to introduce Adam, and Adam's going to talk about positive behavioural support. So Adam's is an educational and developmental psychologist and has worked across the disability and education and welfare sectors for over 15 years. He's the Managing Director of Lancaster Consulting Australia, which is an independent non-government organisation that provides a range of specialist services for people with intellectual disability, complex needs, their families, and their wider support network. So Adam, I might just hand over to you. Thank you for joining us this morning.
Brilliant. Thank you, Robert. Thanks for the introduction. As you said, I'm an EdDev Psych, so I've been doing this type of work for quite a long time, and have seen the way in which positive behaviour support has grown in the Australian setting over the last 15 years with the onset of the NDIS. So I'm going to kind of chat a little bit about more broadly what positive behaviour support is about, and then look at some of the key components of the PBS philosophy or the framework, and then chat briefly about how that fits into the NDIS landscape, all in about 10 minutes, and I can spend about 3 days talking about this. So let's see how we go. So for me, what is really important to understand is that PBS, or positive behaviour support, is a philosophy on how we think. It's not a set of strategies. It's not a guidebook around supporting individuals with diverse needs. Really, it's a framework that we go through to understand why people might do what they do, understand the impact that their behavioural presentation might have on their quality of life, and develop strategies using a whole range of different mechanisms to try and encourage a quality of life that we would all want for the people in our lives. So PBS is kind of founded on some clearly established science principles of behaviour that have been established for decades through psychology, and uses this knowledge to apply our understanding of somebody's engagement in their world. It's grown from quite a rich history of knowledge of learning theory and its application through frameworks like applied behavior analysis. And back in the 60s or 70s, it kind of combined that knowledge with the onset of person-centered values and the normalization movement in disability, and has kind of then developed into this go-to framework that's used worldwide around trying to understand the way in which somebody's engagement in their world and the way in which their behavioral challenges might be understood and then supported to ultimately increase that person's quality of life and reduce some of those behavioral challenges. So there are in my mind, two key interrelated themes that underpin the positive behavior support philosophy. So the first one is that all behavior and actions as we do as human beings happen for a reason. I often will say that behavior doesn't just happen just cause. There's always a reason or always an underpinning need that is being met for the person engaging in those behaviors, whether we label those behaviors as challenging, negative, concerning, or vice versa, those behaviors that we might see as quality of life enhancing, positive, engaging. Everybody does stuff for a reason. And often then when behaviors pose a challenge to a person's quality of life, these are often because there is an unmet need. So the PBS philosophy or framework tries to understand these two interrelated components by firstly ensuring that we understand the needs of an individual and the way in which those needs are met to promote that person's quality of life, and then also understand where there are barriers to that, and mostly through behavioral presentations that we might see as challenging or concerning. And that's regardless of why those barriers appear. What we want to try and do through this framework is understand the underlying needs that aren't being met, or the underlying drivers of those behaviors that we identify as concerning or challenging to a person's life. So firstly, the key component of positive behavior support that I like to preach is that it's not about a reduction in behaviors of concern. It is about a quality of life enhancement. And as we are pushing that quality of life enhancement for a person, we are absolutely going to see reductions in challenges that might occur for that person, but that's not our goal. Our goal really is to enhance that person's quality of life in everything that we want to see, that active engagement, that really great health, really great connection, really great activities, all of those components of a person's quality of life that we would like to see for ourselves, our loved ones, and everybody else in the community. And as a result of doing that, we then will see a reduction in behaviours. We may put in place strategies that address specific behavioural concerns, but again, the goal is not just for the elimination of those behaviours. The goal is to understand that those behaviours inhibit that person's quality of life, and we want to then increase that. So we do this through a number of different areas. Can you chuck the next slide on, please, Whitney? So often when I talk about positive behaviour support, I use a pyramid analogy. And this is because it's like a structure. When you think about the pyramid, the most important thing is a really solid foundation. And for positive behaviour support, that solid foundation is around understanding personal information. So without understanding the person, without going through the required needs to gather information about their goals, their support needs, their history, other components such as their communication or their diagnostic makeup, we're not necessarily going to be able to do much in terms of shifting that quality of life. So like any structure, the PBS framework is really built on that solid understanding that we need to get an idea of who the person is, what drives them, and we need to then ensure that we're matching our strategies to enhance those components of a person's life. So, for example, if I am a person that really loves music, then rather than just looking at some of my behavioural presentations and what might be inhibiting my quality of life, we're going to put strategies in place in my plan that will promote my access to music, the things that are going to be driving my kind of everyday quality of life. And we're going to then embed those strategies in our base support plan in order for that quality of life enhancement to occur. So once we get a good, solid understanding of the person, what we then want to think about in our next step is identifying any behaviours that might challenge or inhibit that quality of life enhancement. And we do that through some of those learning theory components that have stemmed from a really rich science background. And we often will engage in what's called a functional behaviour assessment. And as the name suggests, what that's trying to assess is the function or the meaning behind that behaviour. What's driving that for the individual? And we can do this through a number of different mechanisms. One of the key ways that we do this is through kind of old school antecedent behaviour consequence assessment. So trying to understand some of the drivers of those behaviours. We also look at the mediators, so the things that are impactful for the person that might not be directly related to that person's specific makeup. So it might be things like the support network around them, the skills of the family or the support system around them to embed positive supports. And then we also look at the environment. So what we do here is we understand the impact of the person's physical environment, their support environment, and how that influences and impacts their behavioural presentation. And then with all of that information, what we do, the lovely little tip of the PBS pyramid, is we develop a really solid holistic support plan. And those who are in attendance of last session with Dr. Chad Bennett, he talked about some of the different components of a holistic support plan. What we see here is that they often will fall into 4 key areas. So one of them is around our environmental supports. And what we mean by that is ensuring that the supports within the environment, the communication, the sensory supports, the direct supports that a person's requiring suits that person's needs. We also then look at developing skills by increasing skill teaching opportunities. We look at short-term strategies that might assist and shift behaviours in the short term. And then we also develop a really solid response plan. So if behavioural concerns do happen, how do we minimise or mitigate risks at that time? So that's kind of a really quick overview of the different components of PBS. Next slide, please, Whitney. Just really quickly, PBS within the NDIS landscape take on a bit of a specific oversight in terms of behaviour support practitioner responsibilities. So it's embedded in some of the NDIS rules, so the legislation surrounding restricted practices. So often when a person has restrictive interventions in their plan that try to kind of minimise risk or challenge for the individual, or engage in behaviours that are of a significant level that inhibits their active engagement in the community or their own life, behaviour support is often then embedded in somebody's NDIS plan. So that can range from kind of 10, 15, 20 hours over a 12-month or a 24-month period, right up to hundreds of hours, depending on the support needs. And the role here is really to understand how we can use this philosophy of positive behaviour support to reduce restricted practices in that person's life and also, as I said before, increase that person's quality of life. So there's lots of information around positive behaviour support. The NDIS Commission has just recently, in the last couple of weeks, produced a range of participant handouts on the use of positive behaviour support under the NDIS framework. So they're worth a bit of a geezer at, because they're quite good information for yourselves. That's it from me. Are there any? Can we open up for questions now, or do we wait for later?
Absolutely, I think it's a great opportunity to open up some questions. Does anyone have any questions for Adam? I'd like to ask Adam, how, as a GP, would my patients automatically be hooked into a behavioural support practitioner, or not necessarily?
It depends.
It's not an automatic thing.
Yeah, it really depends on the way in which the
absolutely frozen there.
Am I back?
You're okay.
I'm okay.
It's Robert that's left us.
All right, great. So the question I think most people got was, are patients of GPs automatically linked in? The quick answer is no. It's really through their NDIS planning process. So if there's identification of behaviour support needs or restricted practices in a person's support network, then that will often trigger the engagement or the funding to be placed in a person's NDIS plan for a PBS practitioner. If somebody's not eligible for the NDIS for whatever reason, if they're engaged in state-based funding for disability, often through their planning processes there, they may engage with a positive behaviour support practitioner as well. So the short answer is no, it's not an automatic. If they have behaviours of concern, they get a PBS practitioner, but a lot of the planning processes are getting a whole heap better in terms of asking those specific questions.
Can I make a comment, Robert? Is that okay?
Absolutely.
GPs are often looked at as a quick fix, as Robert said, and to apply their knowledge of the PBS, i.e. prescribe, to the more general term of PBS. So there was a situation with my son where he was at the end of each day program assaulting staff, running away down the road, ripping windscreen wipers off cars, and refusing to sit down in the bus to go home. The staff wanted him taken to the GP for something to calm him down because he was obviously very agitated, and they also wanted seatbelt restraint used in the bus. When we looked at that situation more broadly, then it was he had not moved out of home for long, so it was within the first 3 months of him moving out of the family home. The staff at the house where he was living was highly unstable, so people didn't know him and couldn't communicate with him. He doesn't use speech to communicate. And his behaviour was saying, I don't want to leave. The security that I know in my day program, where people understand me and where I have things that are rewarding to do, I don't want to leave that and go to a place that's empty where I feel lonely and isolated and nobody understands me. And his way of doing that would become more and more violent at the end of the day. And so it's really hard as GPs because it's hard to have the time to ask those questions to get the broader picture. But unless you get the broader picture, you can't understand what's happening.
And your example, Jane, of your son's a really great one of where that quick fix, if you put a chemical restraint or a mechanical restraint like a harness in a car, It doesn't address any of those underlying reasons why he was having a really rough time at that stage in his life. And without taking that holistic view, we're just we're trying those band-aid approaches, and often it has even further detrimental effects on a person's quality of life because we're not understanding those underlying reasons.
So the role for the GP in that case was really to be an advocate, to say to the department, this young man needs predictability and consistency in his life at home, and you need to get your staffing of your house sorted out if you want the behaviour sorted out.
I suppose it's good with a session like this, Jane, to remind us all the other professionals who are there to help us to deal with that, rather than just sort of having it lumped on that, because we do get it say presented with a carer or with a patient and a problem that, you know, in 10-15 minutes they want a solution for.
That's right. And so it's important to resist that and to go for, well, what's the story here? You'll need to get more of the story. I mean, I don't mean the GP necessarily, but to ask somebody, the support coordinator in this case would be somebody that you could get to say, well, I don't understand why this change, because it's about change. You know, he had not done that before and he now started doing it. So it was a clear change in behaviour. Something had happened and somebody needed to understand that. And providing a benzo or an antipsychotic to treat that change in his environmental circumstances would have been entirely inappropriate.
Evelyn, you've got your hands up. Welcome, Evelyn.
Hi, Rob. Thanks very much, Adam. That was a great presentation. I work at the Royal Children's Hospital in Melbourne and often am involved in helping families navigate that behaviour support referral, and have referred quite a few families to you and your practice. So I'm interested to know, I suppose, as part of understanding the holistic needs of young people and their families, there are services that I've come across that seem to cater more for high-level behaviours and more severe behaviours, and those that are a bit more light touch. Some families engage with behaviour support services that might be virtual only and based in Mansfield and other sort of regional areas or interstate. So what's your view, I suppose, of these sorts of services? And I guess with the advent of telehealth and telemedicine coming to the fore, I guess in your view, is there advantages or disadvantages to those sorts of services as opposed to face-to-face type services? And what would you recommend for families who are struggling to find behaviour support services at this time?
How long have we got? Because I could probably speak for hours on this, but I'll try and keep it very quick. The PBS landscape in Australia is still quite new in the way in which it's kind of played out currently. So you do have a very diverse range of practitioners. It's currently a self-assessed role. So there's no qualifications that go alongside being able to call yourself a positive behaviour support practitioner and be able to access funding under the NDIS. There is a registration process, both at the organisation level and the individual practitioner, but you get a vast range of skills within the sector. And you also get a vast range of ways to practice. So some are really hands-on and provide almost a therapy-based engagement, which is often not what positive behaviour support under the NDIS and more broadly is about. So we will often get referrals for people who have said, oh, our previous behaviour support practitioner came out weekly and did an hour with our son or daughter. Are you going to do that? And we say no, because it's a consultative model. Really, it's about assessing and understanding and support planning, and then helping the established support network to implement those strategies. So depending on some of those barriers, something like telehealth services can be really effective if there's no access to local service providers. However, you miss a whole bunch of those nuances in understanding the environment and the way in which behaviour is a result of all of those factors mixed in. So it's often depending on what's available. Often some of the big organizations that have a really well-established reputation have waiting lists. Those who are new in the field and might not necessarily be as adept at engaging with some of the more significant support needs may be able to pick up a client tomorrow. So there's some of those kind of systemic issues that are appearing as well. It probably doesn't answer all of your questions, but we could talk about that for hours.
Thanks, Adam. It's really helpful.
Adam, can I ask, when someone's you've got a patient who's involved with an organisation or a care organisation, who do you get most of the information from? Or where do you get that information?
It's a bit of everybody. And also depending on how big a scope we have. So if we've got hours or time to play with, we will want to chat with everybody in that person's network, including GPs, including specialists, because everybody has their own kind of bundle of information that adds to that base of that PBS pyramid. There are all those kind of those bricks, I suppose. If you just concentrate on one person, if it's a direct support worker or if it's a family, you're getting quite a minimal amount of information. Some people have a great depth of info, but it's not the same as getting information across multiple people.
Yeah. So do you get from organisations, would you get information from their sort of electronic sort of risk man? Information about behaviours and things like that.
We'll often we always request it. Most of the large organisations that have been well established just say, here you go. This information's not ours. A lot of newer service providers are reluctant to share information, and so that's one of the barriers to really great support is a lack of information. And you've also then got a very, very clear range of information gathering. To some organisations, you get one line about a support for a whole day. Others, you get an essay of everything that person has ever done from the moment they wake up and everything in between. So yeah, we do request it all the time, but it's just whatever's available. We advocate strongly for really good information gathering because we can't do a thorough assessment without information.
I'll just highlight that some providers have started using the QR codes now to document incident reports in an app. Right. So they'll scan a QR code after an incident, and then they will record the incident report. So then the organization can extract specific details about that incident and then send it straight to us as practitioners, which has been a positive benefit of learning how to use QR codes through the pandemic.
Look, we're really getting to the end of our time today. I'd just like to thank everyone for their participation, particularly our presenters, Adam, Jane and Zach, and Nikki. I'd just like to remind people about the health pathways through the Westvic PHN, where there's a lot of sort of subjects there that you can click onto to get some advice or further information, and that's always available to GPs. There, I'd like to just acknowledge the SPIDER team, we've had them here with us today, and the terrific job they're doing advocating for people with intellectual disability within the Westvic PHN region and organising these echo sessions here. Just like to remind people for case studies, we had the great case study from Nikki today, that if anyone else has a case study they would like to present at any subsequent echoes. And to remind people just to fill out the evaluation slide, which is really important for people planning.
Wow.
Okay, thank you, Nikki. So I'd like to remind everyone about the next session, which will be in a fortnight's time at 7:30 again, and we're going to discuss the principles of restraint and restrictive practice, and reducing chemical restraint. And our presenter will be Mandy Doley, who's the Victorian Senior Practitioner from the Office of Professional Practice. And once again, we'll be joined by Jane Tracy and Andrew Pritting, who's from the Victorian Dual Disability Service. So thanks once again for joining us, everyone. I hope you've have a good day and enjoy the rest of the week. And hopefully we'll see you in a fortnight. So thank you.
Well done, everyone.
Thank you.
Thank you. Thanks, everyone. Bye-bye.